So good morning, good afternoon to all of you. A very warm welcome on behalf of the IEPB events team to today's webinar, 2030 Insight for Our Children. I'm now delighted to hand over to Jissa to welcome you to today's webinar. Thank you very much.
Welcome everyone, and thank you for joining us today. We have 90 minutes together and let's make the most of it. This is an exciting week for child eye health. The leaders of Commonwealth nations made a landmark commitment, especially on child eye health, at the just concluded Heads of Government meeting in Rwanda. And to quote from the communique, taking note of the progress made in increasing access to quality eye care, a multi-pronged approach for access to screenings and affordable vision treatments, especially for children. They encouraged this, and cheers to all my colleagues and others who worked really hard to elevate child eye health in this space. So what is planned for today? This webinar today will discuss actions that we need to take now to accelerate efforts to elevate, integrate, and activate child eye health to meet the growing eye care needs among our children. We will hear 3 examples that have been successful in creating an impact. And then as a panel, we will discuss child eye health and the changing and increasing needs of today and actions that we need to take now for the coming decade. I would like to acknowledge and say a big thank you to Cooper Vision for sponsoring the program and being a part of our Focus On initiatives. Before I introduce our speakers, can I please ask all of you to introduce yourselves in the chat? It will be so lovely to know who is in the room and pick up a conversation now or a bit later on the platform. We had great engagement and a wonderful discussion in our first webinar earlier today, and I'm excited to see what you all have got to ask and share. On that note, I'm so glad that joining us are experts from the field who have made significant contributions in the field of child eye health and helped us understand the need, the importance, the challenges, and the way forward to make our children see better and have accessible, affordable, and quality eye care when and wherever they need it. So who are our speakers for today? We have Priya Mujaria, Milka Maffari, and Andreas Muller, who will talk to you through the examples, and Riswana and Professor Catherine Saunders joining us in the panel. Priya is Head of Global Program Design at Peak Vision and is also the co-chair of IEPB School Eye Health Workgroup. She's Assistant Professor at the International Center for Eye Health and has worked on eye health research in multiple countries, specifically around Africa and Asia, and with a focus on school eye health services. Joining us is Milka, and she's Associate Professor at Muhimbili University of Health and Allied Health Sciences, and she's engaged with training, research, and consultancy. And she also coordinated the Muhimbili Childhood Blindness Prevention Initiative for almost 8 years. A focus of her research is on integration of eye care for children into the primary health system in Tanzania, which we will hear more about. We have Andreas Muller. Andreas is a consultant to the World Health Organization's eye care program, leading the development of the recently released Guide to Action. He has worked across various sectors of the public health field, supporting eye research and prevention of blindness initiatives in academia, the non-government sector, and also within the UN system. Like I said, joining us later in the panel is Dr. Jamil Riswana and Professor Catherine Saunders. Riswana currently heads the Rivoli Vision Academy at the Rivoli Vision UAE. She has been a faculty member and mentor for the Looking Towards the Future optometry program in advocacy and leadership run by WCO, and is also a member of the WCO's education committee. She has been involved in a number of school eye health initiatives for over a decade now. Professor Catherine is a senior academic at Ulster University with a special interest in children's eye care. She has published over 90 peer-reviewed scientific papers whose topics center on the development of visual function. And she's very passionate about evidence-based eye care and equality of access to eye care services. There is a lot more to add to each of their credibility and experience, and you can read more about what they do and how they interact in this space or in our webpage. So thank you everyone for all your efforts and time into this webinar. Before we crack on with the presentations and discussions of the day, we would like to start off with two questions. Let's go to poll number one. And what I have for you here is, without using your job title, can you describe what you do? Please do key in your role and what you do. You can click on the Slido tab next to the chat and the Q&A box. There might be a slight delay in for me to see your responses. So I'll wait for a few seconds more. Build partnerships, of course. How can we not stress about it? Engaging with stakeholders towards school eye health advocacy. You're an eye care professional. Providing eye care services. I can see some comments as well. Eye health coordinator. It's interesting to note that we have a group of people who work from different angles in child eye health. In the interest of time, I might just have to move on to the next poll. I can see that advocacy and program management also belongs to the profiles of people who are in here. The next question for today up for poll is, what are issues in child eye health that need urgent attention and intervention in the setting you work? If you all could please get into the Slido tab on the platform, that would be really helpful. Vision Guardian. This is a word cloud, so I would like to see a few more responses coming in. Universal or integrated screening. This came up in the first webinar as well. Lack of integration, reduced awareness. It's interesting to note that, the comprehensiveness of our programs are taking a real importance in the discussions. High impact evidence. Pediatric vision assessment. Private sector endorsement, yes. The lack of integration, very interesting observations. ROP screening and nurses training, if I'm getting that right. Lack of trained professionals. Engagement of parents. Thank you for your responses. We had very similar observations in the first webinar as well. So we'll come back to Slido and with more engagement opportunities, but let's move on. So to frame our discussion, let me present some numbers. Some of you pointed out to the high impact evidence. As of 2021, globally, close to 26% of the world's population were under 15 years old. Over 90 million children and adolescents live with vision loss. Around 4 out of 10 children that are blind have eye conditions that could have been prevented or could be managed if the child had access to eye care services. It is also estimated that half the world's population will have myopia by 2050. And there is increasing amount of evidence is coming through wherein we say that during the pandemic, we have seen a rise in the progression of myopia. 2030 Insight, our new sector strategy, recognizes that we will have to work differently to make sure eye health is recognized and prioritized in the broader health, economic, social, and development agenda. We'll need to embed eye health as a fundamental development issue, integrate within our sector and wider healthcare, and activate consumer demand and market change. How do we plan, advocate, and action this for child eye health? I'm moving on to the recorded presentations and examples that I spoke about a while back. And we have to present on the Elevate theme. I have the presentation from Priya. Good vision and eye health help unlock better educational outcomes, yet eye health is often not addressed in school health and educational policies, plans, and practice. The Sustainable Development Goal 4, quality education, cannot be achieved if child eye health is not included. It needs political prioritization and resolutions, development plans, national policies, and budgets relating to achieving quality education. And the SDGs doesn't stop here, and neither the connection. School eye health policies, plans, and practice have shown to be cost-effective in multiple settings. On that note, let's hear from Priya on elevating and advocating for child eye health and why this is so important.
Thank you to IAPB for the opportunity today to talk about child eye health and its importance from the perspective of the Elevate theme in the sector strategy. From a child eye health perspective, the Elevate theme focuses on embedding child eye health into development plans, national strategies, policies, and budgets. You may have heard me speak about school eye health programs and frequently refer to the statistics on the number of children that have a vision impairment. Globally, school eye health programs are common and implemented in many different ways, and they also have the potential to change the lives of millions of children. Over 90 million children worldwide have an eyesight problem, ranging from mild vision impairment to blindness, and the problem is only getting worse. And if we just think about the sheer number of children, over 25% of the global population consists of children, and 40% of the population of Africa is under 14. Therefore, school eye health programs are important, and they're much needed to help identify children with eye health conditions in a timely manner. However, these programs must be comprehensive, sustainable, and focus on the eye health needs of children. We often advocate for school eye health, and we talk about the large numbers, and it's quite easy to get lost in them. So I want to share my experience of meeting Mariam. I met Mariam when she was 13 years old, and I remember her very clearly because she could barely see a few meters ahead of her, and as expected, she was severely myopic. I'm never going to forget the expression that she had as she looked through the trial frames, the smile and the mixture of pure joy and shock. And she picked some pink frames that she was excited to take home. Part of the work I was doing was addressing the stigma that surrounds glasses wear, especially for girls. And so I remember returning to Mariam's school about 3 months later, where we were investigating compliance. And I was really looking forward to seeing her and finding out whether she was happy and wearing her pink glasses. At the end of the day, we looked at the list of children that were absent, and I recognised Mariam's name. So I asked the teacher about her. She ran back to the classroom and returned with a dusty glasses case labelled Mariam. She handed me the case and said that Mariam wasn't at school. So I explained that fine, we're not here to take back the glasses. But she shook her head and said, no, Mariam is no longer at school. Mariam hadn't been at school for the past 2-3 months. In fact, she had probably just used her new pink glasses for a week or two before she was removed from school, as it was time to get married. The Lancet Commission on Global Eye Health included an in-depth look at the relationship between eye health and the SDGs. And there's enough compelling evidence to prove that improving access to eye health services for children will contribute to achieving many of the Sustainable Development Goals, including SDG 4. There is evidence that providing children with glasses improved their academic test scores. Results from a randomized control trial in China show that providing vision correction reduced the odds of failing a class by 44%. In other studies, glasses were improved reading and word identification and attendance at school. But it's not just about this direct link between education and child eye health that's important. Child eye health impacts the other SDGs too. SDG 3, good health and well-being are also affected. When a child has poor vision, their ability to socialize, interact with their peers, and their general confidence is also impacted. Gender equality is also important to address when it comes to planning child eye health services. When girls are not at school or are forced into early marriage, they are already disadvantaged. Like Mariam, they will not be able to achieve their maximum potential. While there has been progress over the last decades, more girls are going to school, fewer girls are forced into early marriage. There are still girls like Mariam who, despite all our efforts, are not accessing the services they need, and the challenges remain. We all agree that school eye health programs are important, but how do we improve these? How do we address the challenges that we're now faced with? While I don't have the answer, but any solution to a problem this big in terms of numbers and complexity requires a solution that's innovative, relevant, and most importantly, appropriate. School eye health programs need to collaborate and engage with the health and education sector. And while this is already happening in some programs and regions where school eye health are a part of nutrition or vaccination programs, this isn't happening consistently. Collaboration and inclusion of government, health, education, and even finance sectors, non-governmental organizations, civil society, researchers, innovators, and private sector is the key for the future of school eye health. There has been a number of collaborative efforts that have made great strides in this, such as the previous Our Children's Vision campaign, the Orbis Reach program, Eye Alliance, etc. But the challenge now is, how do we engage as a sector in unison to make sure that all our efforts together are having an impact? Sometimes when we are in our own settings and doing our roles, all these discussions and ideas seem very abstract, and you don't know where to start or what to contribute. So I'm going to share a quick example of an opportunity that was created a few weeks ago when IAPB hosted an event ahead of the Commonwealth Heads of Government meeting that happened in Rwanda last week. A few of us started talking to each other about the status of school eye health screening in the UK, something that's not standardised or in fact available throughout the UK. And it just so happened that one of the persons in this conversation was a crossbench peer at the House of Lords. This conversation progressed outside of the event, and last week an amendment was tabled at the House of Commons by her. Now, while this doesn't mean a change will happen tomorrow, it does mean that we've been able to raise a question about annual screening for school children in the UK. And this has taken a very long time. But this only happened because we took advantage of an opportunity that presented and had a very clear ask. This slide speaks for itself. There is an interest in school nutrition, in eye health, in vision, in the well-being and welfare of children by sports personalities, celebrities, corporates. And I think we need to be more open and engage with different sectors. In the interest of time, I'm not going to go into the details of each campaign, but on this slide are Marcus Rashford, an English footballer, Virat Kohli, an ex-Indian cricket captain, Amitabh Bachchan, a very famous Bollywood actor, and Disney's new heroine, Encanto. While I'm not suggesting that we start spending our budgets on celebrity campaigns, what we do need to do is become more innovative with the opportunities that do become available to us. And I'd also like to encourage everyone to participate in advocacy campaigns that are led by IAPB. They continue to do incredible work to drive eye health up the global agenda, but it is an uphill battle. So I never saw Mariam again, but years on I still do think of her, and I have her pink glasses to remind me of why we still have a long way to go to ensure that school eye health programs are of a good quality and that they're no longer standalone and one-off initiatives. They have to be sustainable programs that are embedded within school health and education and social services, and they have to be programs that are comprehensive. Thank you.
Thank you, Priya. I can't agree more with your thoughts on us being innovative and grabbing every opportunity that comes our way. And of course, about collaborating well beyond our sector and to speak for our children. Thanks once again. Let's move to the next presentation for today. As a sector, we will need to come together to work differently. Integrated people-centered eye care looks at reorienting the model of care, coordinating services within and across sectors, and creating an enabling environment. We need a holistic, integrated approach where eye care is treated as an essential element within the wider healthcare services and is universally available to everyone. We also need to ensure there is integration within and between the different eye care professions. Let's hear from Milka about her work in Tanzania on integrating child eye health in the primary health setting.
So thank you very much. So today we are talking about the integration of primary eye care for children into the general child health system. Why do we integrate? Why is it important? We know that many diseases, for example, measles, that cause child mortality and morbidity, are also the causes of visual impairment and blindness, but they are also preventable at the community or the primary level. So it is important to integrate in order to share resources, including human resources. For example, one nurse may be performing general eye care at the same time performing eye care. Also share the infrastructure for the promotion talks and materials, but also we can share funds in order to reduce the implementation costs. And lastly, to provide comprehensive health promotion messages that are important for eye care, because eye care is part of the general health talks. Now, what do we mean by integration? We mean that eye care for children is being implemented within the general child health system in order to ensure that every child who presents to the child health services is screened for eye problems. Now, we need to include in the routine general care of the child, we need to include newborn eye screening, and also that all children who cannot see, or those who have a white pupil, or those who have serious eye injury need to be referred to the eye worker as immediately as possible. But other things is also to practice cleaning eyes at birth and application of antibiotic, not to use traditional eye medication, but also to include eye health education messages in the health talks that are given at the clinic. Now, how can we integrate? We can integrate by training primary healthcare workers in child eye health so that they are able to screen and refer appropriately. We can also integrate by increasing awareness in the whole child health team about child eye conditions, for example, obstetricians, pediatricians, physiotherapists, midwives, and others. We can also integrate by working in the community with teachers, community health workers, parents, caretakers, and even drug distributors. We can also integrate by sharing data for monitoring. Now, how did we manage to integrate child eye care in Tanzania? Now, firstly, we had an evaluation of a pilot study where we trained primary health workers in the 10 keyword health organization activities for health eyes. And we found that there was inadequate knowledge and skills among primary health workers. But that improvement, there was also improvement after the training, improvement in the knowledge and skills after the training, which was retained to about 1 year. We then conducted a formative research in rural Tanzania and created a theory of change. In that study, we also found baseline situational analysis of mothers and caretakers' knowledge of eye conditions and behavior towards anybody who is sick with eye conditions. We also reviewed the clinics in terms of the number of children seen, the available consumables and equipment. And also we looked at the primary health workers' knowledge and practices regarding child eye health. Now, further, we continued other steps by asking ourselves, how can we integrate child health into the general health system? Which fora can we use? And then we thought about the IMNCI. The Integrated Management of Childhood Illnesses is a program which is implemented globally in more than 100 countries. And the aim is to reduce mortality rate among under fives. And so it is a program which is well implemented in Tanzania by primary health workers, mainly at primary health facilities. So in Tanzania, training of primary health workers is done as in-service training. And so we thought this was a better forum where we can enter to include child eye health. Now, we conducted a stakeholders meeting where, after explaining our intent and what we wish to do, a consensus was reached by the Ministry Health, agreeing to develop a program which could be included in the training of IMCI. So we developed the eye health module, which is called Module 6. Pilot tested it in real life IMCI training. That is, we had to train IMCI the usual way, but including the eye health module. And from there on, the eye health module was included in the training of the national IMCI, and it continues to be trained to date. So what impact has it brought? Until now, on every training of IMCI in the country, the eye care is also included, and we feel this is sustainable as it will continue being trained all the time. Until now, 3,000 primary health workers have been trained from 2018 onwards. And our plan for the next phase is to have evaluation of the national program where IMCI is being trained, including the health module, and this will be in collaboration with the London School of Hygiene and Tropical Medicine. We hope that apart from evaluation, scaling up of the program is possible. We are very thankful to the people who worked with us, including London School of Hygiene, MUHAS, the Ministry of Health, and all these people that were very instrumental, not forgetting Professor Claire Gilbert, who worked tirelessly in this project. Thank you so much for listening.
Thanks, Milka. That's an incredible example, and I'm so delighted to know about the progress this intervention is making and speaking about a sustainable and scalable model. Looking forward to listening to you more. Moving on, we will now have a presentation around Activate from Andreas, empowering people to demand eye care services by making them more aware of what they can do to look after their own eyes is essential to ensuring access to quality eye care services. This should start from childhood, where individuals have all the information they need to protect their own eyes and, crucially, take the steps needed to look after their vision, from taking regular breaks from close work through to seeking help for any ailments or discomfort. This level of awareness and demand should flow through every single person's education pathway and employment environments. Andreas will now present on the World Health Organization's Myopia Ad program and the impact envisaged to influence individual action.
My name is Dr. Andreas Muller. I work with the WHO Vision and Eye Care program at headquarters. And I would like to thank IAPB for inviting me to this important webinar on focus on child eye health. I was asked to present on a new WHO tool named the Myopia Ad. And I will start off with some background information. Most of you will be familiar with those. So as you're all aware, myopia represents an important public health challenge globally, with well over 2 billion people being impacted. Importantly, and although the correction with spectacles is highly cost-effective, uncorrected myopia is a leading cause of vision impairment in children and adults. We do know this problem is escalating, and the numbers are expected to be well over 3 billion people by the year 2030. In recognition of this challenge, and for the first time, WHO member states recently endorsed an ambitious new global target for refractive error at the 74th World Health Assembly in 2021, namely a 40% increase in effective coverage of refractive error by the year 2030. This is a very ambitious target, and WHO recognizes that a comprehensive approach is required in order to achieve this target. With this in mind, WHO and the International Telecommunications Union, or ITU, have developed the Myopia Ad Toolkit, recognizing that improving public education is critical in the management of refractive error and to drive the demand for spectacles, particularly in lower income settings. The toolkit, the Myopia Ad Toolkit in itself, has two key components. First, there's the evidence-based message library to be delivered to individuals in the population. Second is a handbook or toolkit which contains background information, but more importantly contains guidance and resources required to support any country or stakeholders in a step-by-step fashion through the planning, the developing, the implementation, but also monitoring of a digital health message initiative targeting myopia education. So now let's look at some of the aims and objectives of the Myopia Ad program. The first objective is really to support behavior change that contributes to delaying the onset, and also possibly slowing the progression of myopia. This is particularly important considering that we see complications from high myopia are now an emerging cause of irreversible blindness in some regions of the world. The second objective is to improve awareness and health literacy of the importance of regular eye examinations and to comply with spectacle wear amongst people with myopia. This is important because we know that even when children or adolescents do have access to spectacles, quite often they don't wear these specs when they should due to a range of misconceptions, but also stigma at times. Who is the target population for Myopia Ad? The program targets 4 distinct segments of the population and separate message libraries have been developed for each of them. First, the general population involved in the care of children. Second, parents or caregivers of children with myopia. Third, the adolescents with myopia and also adults with myopia. What are the key themes of the program? The general themes of the messages in the Myopia Ad program cover education, such what are the causes, what are the warning signs, and addressing some of those misconceptions that we heard before. Then, themes targeting those lifestyle behavior changes that we implicated, in particular delaying the onset of myopia. This includes in particular promoting increased time spent outdoors amongst children and also reduced intensive near work activity such as the use of devices, particularly during leisure times. Thirdly, a key theme is the importance of regular comprehensive eye examinations in children. This is very important, especially considering children's eyes and prescriptions are constantly changing. Last, the program promotes compliance, meaning the fact that spectacles are safe and they should be worn regularly. Now, how is the program and its messages designed to be communicated? Firstly, the program design is a recommendation, and any country or any implementer of Myopia Ad can adapt this in line with the resources they have available and also the local context. At the moment, the structured messages have been designed mainly for one-way SMS delivery. This can be used in other messaging modalities, for instance WhatsApp or WeChat, and also social media. The message libraries also contain some multimedia suggestions that can accompany the messages where this is also possible. The duration of the program is such that individuals who sign up for the program would receive messages over a 6 or 12 months period. Now, this period is in line with evidence that this is the amount of time that is typically needed for a behavior change to be incorporated in a person's life. In the acute phase of the program, the individuals will receive messages at a higher frequency, and this decreases over time so not to overburden the user. The messages are categorized into one of 4 domains: motivation, support, information, or reminders. Here I provided a few selected example messages in each of these domains to give you a taste of the actual messages. So, for instance, did you know if a parent has myopia, their children are more likely to develop it too? Regular eye tests will be important to detect myopia early. Or research shows spending more time outdoors lowers the risk of myopia. Encourage your child to go outside and play. Or worried about your child developing myopia? Remember, eye health professionals are here to help and support you. Or remember to wear your glasses every day at school. This will help you see things clearly in your classroom. Who are the intended key end users of the Myopia Ad Toolkit? The Myopia Ad Toolkit targets government officials, academics, and other in-country implementing partners who are involved in deploying large-scale digital health intervention programs. However, the Myopia Ad Toolkit and messages are available for anyone or for any individual or group to use in their efforts to promote, to improve or promote population education on myopia generally. Lastly, I want to touch on what the eye care sector can do to support Myopia Aid. First, I see that there's the opportunity for technical support. Partners might provide translations, might carry out adaptations or revisions of the messages based on cultural realities in their countries, or they might carry out evaluations on the impact of the program in a country. Where necessary, partners might provide funding where countries lack the required resources for a myopia prevention campaign, or, and very importantly, partners might raise awareness about myopia as a public health problem and about the existence of the Myopia Ad Toolkit to be implemented. With this, I'd like to end my presentation, and I wish you all a successful webinar.
Thank you, Andreas. Great to see eye health specifically part of the digital health initiative, Be Healthy, Be Mobile by WHO. And I know that there are other modules in this program about conditions relevant to eye health as well. So please feel free to check these amazing resources out. And it is also equally interesting that it's designed to use evidence to affect behavior change. And some of you highlighted the need to address the compliance, the stigma, etc., as a challenge around child eye health. So these initiatives are a great help to address all those aspects too. With the quick presentations down, we are now into our next segment. And before getting into the discussions, can I please remind each one of you, if you have any questions, please do post it on the Q&A session, and we will take it up during the discussion. It's time for the next poll, and I hope you all can get into the Slido tab there. And the question here is, what are the changes that you would like to see actioned for child eye health by 2030? What do you think need to happen? When you get to the Slido poll, you will have to choose webinar 2 so that your answers come through. More integration and financing, of course. We can devise all the policies and plans, but we definitely need funding and appropriate financing to execute our plans. Interesting, more technology at the primary level. Give us a few more seconds to see if more responses are coming through. increased school screening programs, greater recognition of the scale of the issue. Yes. Thank you, everyone, for joining in that discussion. Yes, secure sustainable funding for school vision screening programs, evidence to support and leverage these funds, more training for teachers in basic eye health with children. There were a couple of questions around integration and how the task and responsibilities are taken up by the primary health workers, etc. We can have a much more detailed discussion in the panel. Thank you, everyone. In the interest of time, I'll have to move on from this question. Can I please have Riswana, Milka, and Catherine with me for the panel discussion?
Hi.
Thank you again for joining me today in this discussion. Without wasting any time, I would like to start with an opening question. We know the challenge, the need, the importance, and the urgency with which we should address child eye health. What do you think should we be doing differently? And if I may start off with Milka, if that's all right.
Yeah. Now, thank you so much, Jisan. It's so much important to take action now. And the main issue in terms of integration is to ensure that all the sectors that deal with child health should also deal with child eye health. That's what we mean by integration. So if you have any program which is being conducted to children, we need to include child eye health. For example, if you have obstetricians, they have to know they are dealing with neonates, and therefore they need to know what to do in terms of neonates, what can be done in terms of newborn screening. When you go to the RCH or reproductive child health workers, where the infants up to 5 years are screened for other problems, like if they have pneumonia, if they are being monitored for growth monitoring, then those primary health workers have also to screen these children for eye conditions, because most of the eye conditions, children cannot complain, and sometimes the mothers also do not know. So such a forum where reproductive child health workers are monitoring children growth, they should also monitor if children have got any eye conditions by looking into their eyes and saying whether there is anything abnormal. But in order for these primary health workers to do anything, we need to train them. We need to train them and encourage them to understand child health. Apart from the general health they are giving to the kids, they also need to include child health. That is one of the actions that we need to do, to have as many trained primary health workers to be able to screen and refer appropriately.
Thank you, Vilka. Very interesting observation. And you sort of rightly brought in the question about starting the care right from birth and what we do about it. Can I ask Riswana if you could just add on, do you have anything to add on to that observations?
I mean,
Yeah.
all the speakers so far, I think, sort of convey the importance of integration. So integration, of course, is the key, and I think that's the message. And improved engagement among all concerned stakeholders, be it with respect to policy development or advocacy. when it comes to, our school eye health programs, we need to have both service delivery based models, which are primarily like, that's more in number, but also research centric models, because high impact quality evidence is the key now. So we really need more data on some of these aspects that even Dr. Milka was mentioning. Yes, we know that in the school age group of, like, say, 7 to 17, we have data. But what about the preschool? What about the toddlers? What sort of eye health problems are prevalent? And there is a lot of thrust on myopia. So what about hyperopia? Because good near vision is really imperative to improve literacy and academic performance and all that. So definitely, I think we need more high quality data across all the age range of children to understand the impact of vision on the global development of the child as a whole, and then be able to integrate this into the general health system. I think that's something that's really important from my point of view. Yeah.
Can't agree more. Collaboration comes up again. Catherine, what would you like to add to that?
Just simply that I really agree with Rizwana about the hyperopes and about the non-myopic children. It's so difficult to identify those children without really high quality screening in place. But also I really wanted to say that the Milka's presentation about the Tanzanian project, it'll be so useful to have that evaluation report in a few years' time that really can identify how effective the intervention and the training and embedding that service in primary care will be for the funding in future. Because as everyone has said, we need to have a really strong evidence base to be able to take to the funders, to be able to advocate with, because it's all very good to have little pockets of care that people think are working really well. But until we have that evidence, then the hard cash won't follow. And having some training that's sustainable and continues on, and somewhere for people to go to get their eye care once they've been identified. So it is a huge network of people and changes that need to be made. But I think that evidence is such an important aspect. And there's lots of focus on myopia at the moment, which is great. I do a lot of research around the area of myopia. It's not that we shouldn't be concentrating on that, but we mustn't forget the children with other eye health problems and other refractive issues who are there, and it's really affecting their education and their general ability to make money in the future. And I just think the more we can empower our schools and any primary health contact with parents to include eye health in those contexts, then that would be fantastic.
Thank you, Catherine. Very interesting, in fact, and that sort of brings me to my next question, which speaks about evidence. We have made huge progress with the World Health Organization's report on vision and the Lancet Global Health Commission on Global Eye Health report. And we must continue to develop the research and evidence base to both support our case, support and advocate for child eye health. Could you please throw some light into where are we lacking and what evidence can we as a sector need to bring to the table to elevate our case further? Perhaps, Catherine, if I may start with you.
Sure. The challenge around some aspects of the epidemiology that we need to understand lie in the challenges to make those measurements. So one of the areas that Rizwana brought up was these hyperopic children who go undetected, or anisometropic children who go undetected because their eyes look normal, they're functioning well, they might underperform at school, but that people don't realize that that's because they're not seeing well, or they could go on into adulthood with visual impairment in one eye due to anisometropia that's not been corrected. And the challenge there is that it's not easy to identify those children through just a basic vision screening that measures acuity, distance acuity. So we need to be cleverer about the research and really understand the underlying epidemiology in different populations. So if we're going to Tanzania, the underlying population might have very different refractive needs at age 4 than if we go to somewhere in East Asia, where there'll be much more myopia in 4-year-olds than there would be in Tanzania, potentially. But there's quite a lot of areas of the world where we don't have good epidemiological information for, and that's what we really need, so that we can target our screening so that it's most effective, we're using our money most effectively.
Thanks, Catherine. One size doesn't fit all, isn't it? I mean, and we definitely need to prove the needs of every part of the world to advocate better. Would you like to add anything more to that, Rizwana?
I mean, as Catherine rightly pointed out, when it comes to evidence, it needs to be both country-specific and community-specific. Of course, there are these seminal papers that we've got, but when it comes to be able to advocate, we also need longitudinal studies beyond cross-sectional or snapshot data to assess the efficacy and impact of the interventions. Like for now, we've adequate data that says that yes, spectacle correction improves academic performance, but what happens over like a period of time, because there are aspects of compliance, there are aspects of, because we just can't do one-time screening and say, okay, we've done everything well and good for the child. So what happens to their quality of life, and what happens to the academic performance in the long run? So definitely we've just barely scratched the surface when it comes to evidence, when it comes to community and country specific data. And recent papers, a couple of papers in the ophthalmic epidemiology, pointed out the lacunae, especially in the post-COVID world, as how we coped up with the vision screening requirements, because the vision screening models have sort of collapsed, and now we need to look at how do we reach out to these people. And especially when it comes to children who have reduced accessibility or no accessibility in the high poverty community and stuff like that, how are we going to reach out to these people? So I think definitely a lot of scope is there when it comes to innovation, and when it comes to improving the accessibility, and also when it comes to assessing the longitudinal impact. I think because the next set of data and evidence would definitely require more longitudinal studies. And of course, I'm not going to dig deep into strabismus, amblyopia, and all that stuff, because I think there is so much of work that needs to be really done when it comes to the kids at a much younger age. Yeah.
Thank you, Rizwana. It sort of reminded me back to the story Priya shared about her school eye health work, and Mariam. So, Milka, can I ask if you would like to add?
Yeah, I also, in terms of providing evidence, is very important. For example, in this program that primary health workers are being trained, there are a number of challenges that when we did the formative research, we thought about it. For example, provision of equipment and consumables to enable the primary health workers to work, but also will they be able to continue working, because screening for children's conditions is an additional work. So will they comply to examine children's the eyes of children, but also, or will they feel this is too much and they may not do it? So evidence is very important, because it will not stop at training. Training is one aspect, but ensuring that the primary health worker is doing what they have been trained for is another thing. So that's why we say we have to, at some point, do an evaluation to see how this one is working. And my take is that this should not be the only forum where primary health workers need to get the knowledge about eye conditions. We need to think of other forums where these primary health workers can also learn. But we are encouraged by the issue that before this training, there was nothing that could be taught to primary health workers. So they did not know, if they see, for example, a child who has a retinoblastoma, that is a cancer of the eye, they would not recognize. So they might even delay to refer this child. And when this child is referred, it is too late. So just by being taught, if they hear about this, they may not examine the children of the children's eyes, but knowing this is a step of incorporating eye care into the primary system. So I think apart from evidence, we are still encouraged that something is going to the primary level, which is very important because this is the first point where children and adults start to see a health worker.
Thank you, Milka. Talking about evidence and the impact it can create, not only among the policymakers, but also in the service delivery and continuum of care is really, really important, and cannot mention more about the significance of addressing it much more and beyond myopia. So moving on, can I please urge our audience to please pop in the questions if they have any into the Q&A box. So Rizwana, probably I'll direct my next question to you. So you spoke about school eye health programs and how important it is to elevate and have a comprehensive system around it. Whom should we be influencing and including more into this conversation so that it gets the attention it deserves at a national level in policies, budgets, systems, etc.? Would you like to throw some light on it?
Yeah, I mean, thanks, Jessa. So definitely, as all of us agreed upon, getting some high quality evidence is the key, and then also improved engagement among all concerned stakeholders. So based on my experience with school eye health programs, and also with all the recent evidence that's coming up, I think first of all, we need to be incorporating training and to all IK professionals and teachers. For example, teachers as part of their training curriculum needs to be provided this awareness about vision and eye health problems. I think it's happening in certain communities, but has not penetrated definitely across all the sectors. So definitely, I mean, that's the role, and where we can bring in a lot of technology and objectivity to the assessment, like how Priya's peak and related models have been able to screen, and that will give us a lot of data, first of all, to even advocate, saying that this is the magnitude, this is the burden of the problem. So to me, first, I think it's about engagement among all concerned stakeholders with a lot of upskilling and training where NGOs can come forward, and even in the optometry school, beginning from the first year, the students be involved in all of these vision care activities. Next, when it comes to who should we hold accountable, of course, the speakers did point out to the fact that government is the key. I mean, holding the government accountable, Ministry of Health, school eye health education, because that's the most powerful way to be able to bring in a standard approach to integrating eye care into the general health, into the assessment of the global well-being of the child, as well as evaluating eye health. But again, data on eye health as a key measure, as a key biomarker in influencing the global well-being of the child. Now let's take the current, some of the models that we have where eye care being implemented as part of the nutritional programs or dietary care programs and stuff like that. But then there's a lot of connectivity between eye care, general health, well-being, outdoor activities for overall bone density, improvements in bone density, improved sleep, overall mood and emotional well-being of the child. So I think as part of the entry into a school admission itself, I think eye health should be sort of one of the key assessment factor, and that also improves accessibility to eye care for the child as such. So holding the government accountable, but also using evidence and upskilling as a means to assure them, saying that yes, we've got the workforce, we've got the evidence, and then it's doable. And of course, then comes funding and collaboration and networking. But that would be my sense.
You've covered it all. Can I ask Milka, do you have anything more to add to her?
Yeah, I think just to say we really need to have an enabling environment to ensure that whoever is concerned with child health also does child eye health. And the enabling environment only be provided not only by the government, but also by everybody who is dealing with eye health. But mainly it is the government with all its institutions. For example, in Tanzania, for children, it's the reproductive and child health, which is for under 5s, but also to include eye health screening for school eye health screening, although it is not there currently. But as we see that even the conditions in children are changing, we are starting to see myopia also, which was not very common because of the changing of the environment and maybe too much close awake in children, whatever. All this will lead to bigger numbers of children who are myopic. So school eye health is still very important, even in us. But who should be contacted is the government. We need to advocate, and advocate.
Thank you, Milka. Catherine, would you like to add anything more?
Just reflecting on what Milka said about the introduction of myopia as more of a health concern in her area, just with the changing environment that children in that population are being exposed to, that any screening programs that are put in place will need to be regularly reviewed, because as populations change, as environment changes or needs change and burden changes, they will need to be reviewed. And this idea of key indicators that Rizwana picked up on. I know in the UK or in the part of the UK I live in, there's a sort of health screening done at 2 years of age, and vision is in there, but because it's not one of the key indicators that are reported back when audit is done, if that isn't included, it's not noticed that it's been missed, that it hasn't been undertaken, or it's been undertaken and not recorded. So the sort of quality around those programs and the indicators, making sure that the right eye indicators regularly reviewed are in the right place, so that there's some accountability around the training and it actually having an impact on the child.
Thanks, Catherine. Definitely. I guess this is sort of a pivotal time for everyone in eye health, and there are so much happening from an advocacy point of view. We have the UN resolution of vision. We now have the agreement from the Commonwealth leaders. There's just so much. There's the guide for action coming up from WHO, then the indicators on refractive error and cataract for the countries to act on. So definitely there is scope for us to highlight child eye health as an issue and elevate it among our decision makers and policy makers, and what every one of us to count, definitely. Can I just remind for questions again? So if you do have anything, please do post it up on the Q&A. Moving on, I would like to ask Milka, and this came up in the first webinar as well. Your example and your intervention in Tanzania definitely involves the primary health care workers. So of course, the training and getting them into the system and getting them to know more about child eye health is crucial. But at the same time, the attitude which they bring into the table is also equally important, especially when, child eye health is not part of their profile, let's say. And this could be not just with the health workers, across school teachers are another example. And there are several other categories of people whom we want to integrate child eye health into, but they do not really take it up that way. So do you have any interesting observations to make, or how was there a problem? Or if there was a problem, how did you go around it?
Yeah, of course. Anytime you want to introduce something new, there is usually you'll have the first thing was that the primary health workers were very enthusiastic because this was something new. Before, when they see a child with eye problems, they have no confidence. They would just say, "Oh, this is not my I don't know about this, so maybe take this child somewhere else. But after they have been taught, the first feeling was to feel very happy that I have learned something new. But we know that when they start working, they start feeling like, how do I examine? Maybe it is, I do not see many children with eye conditions. So maybe it is not easier for me to understand what is wrong with a child unless something is very clear. And so what we did was to teach them, we teach them in the module that we have created. Is very simple for them to be able to identify. Now this child has got maybe a smaller eye than normal. Maybe this child has a white pupillary reflex. Maybe this child is not seeing well. Very simple messages, very simple skills for them to be able to identify and refer. So that was one thing that acquiring the knowledge was a bit difficult. But the other thing was getting the consumables. They need a light. They need a light, this is an arc light to be able to do the red reflex. And this took time for them to learn. But once they learned, they said it is okay. But the issue is how long can they keep this light? Because sometimes it is lost in the facility. Sometimes they say they don't have money to buy one. So you think you say, okay, so they can stop examining because they don't have a light, which is actually simple to buy, but then they feel they may not have. So provision of consumables. But the other thing is, how do we make sure that they screen? How do we make sure that they examine the child? Because you are not there all the time. So we need some indicators. For example, to have an indication in the card for the child, which will show that this child has been examined. So to get these indicators into the cards of children is not so easy, as you need to have a review of these tools. And we are working on that, but that is one obstacle that we really need to overcome. Because if they don't show that they have been examined, then we don't know whether they examined them. But the other thing is, they are usually who are called supervisors, who come to the health facilities and collect data. They will collect data on how many children have been given vitamin A or immunization. So when they come, they have to also look carefully to see how many children have been found to have eye problems, how many have been referred, because this will show that these people are working or not. So there are still quite a lot of obstacles that we need to really work on to see how this works properly. Yeah.
Thanks, Malga. I think you made some very interesting observations, not just about the training part, but also providing them with the necessary resources and an active follow-up afterwards to see how the program is working. Interesting. Rizwana, I know you have worked on this field a bit, and would you have any other observations to make?
I mean, I have one of these successful program that I worked with when it comes to integration is like with the government of India. We had a program on early identification of cerebral visual impairment. So as part of it, we worked with pediatricians, pediatric neonatologists, pediatric optometrists, and ophthalmologists. So one of the important component, I mean, the learning that I've had during this entire, building up this program was definitely bringing in standardized approaches to screening. And as Milka was rightly pointing out, what instruments should we use, what techniques should we bring in, and how should we so though everybody have had their formal education, when it comes to really examining newborn babies or like an infant, picking up some of these red flags. So then we developed a manual, and then we provided training based on the manual. So I think some of these structured approaches and bringing in stakeholders and training and upskilling, I think definitely can have a huge impact on these problems that could otherwise have a great impact on the overall visual development and well-being of the child. Yeah, that's my experience.
Thank you, Riz. Catherine, would you have anything more to add?
No, just to really kind of stress that idea about collaboration across different professionals. So it's not just across different professionals from health to education, but even within eye health, not being territorial about ophthalmology, optometry, orthoptics, you know, just thinking about this as eye health, and we can all do bits. Depending on what region you're in, depending on what skills you have, depending on what facilities are available, and not, I think sometimes as eye health professionals, we make barriers about our own professions and where we start and stop and where someone else is allowed to carry on. And that can be so detrimental to making progress. So I'm sure none of us in this room are feeling that way, that we all want to be collaborative and we've got the children's best interests at heart. But I think we need to be aware that those kind of barriers can exist, and we need to be sensitive about how we navigate them for really good long-term positive outcomes.
Thanks, Catherine. Moving on, there is this, we heard about the Activate and how the Be Healthy, Be Mobile initiative and the Myopia Ad program, all focusing on a behavioral change from the parents or the children's side or the individual side to take up care. Now, Catherine, I know you work very extensively in that area, and there is a lot to be done in terms of creating that demand and creating that action-oriented approach from the individuals. Is there anything that you would like to point out to in terms of our approach to generating this demand? Is there anything in particular that you would like to suggest?
Just really to note that parents differ from each other. So not every parent is going to make a behavioral change. Some would rather wait till their child becomes myopic and then put some drops in their eyes to try and slow the progression of myopia. Then other parents will absolutely embrace this idea of, I can make a behavioral change, I can be proactive about my child's eye health, and obviously it's going to be beneficial to them to be outside more, to play outdoors, to have that time away from the screens. So many parents will absolutely embrace that, but not all parents will. I think we need to be realistic about that from the get-go. But it's exciting. It's exciting to have an area of child health that we can have some preventative impact on. You know, I think that's a real positive aspect of myopia management, that we shouldn't just think about how to manage it once it happens, but we've got this whole mitigation area to do as professionals, to educate parents, to educate children that they can take some ownership of their own eye health. And for a myopic parent whose child is more likely to be myopic themselves, I think that's a relatively straightforward message to get across. The challenge is where you have parents that aren't myopic, and they don't realize that because of the environment that their child has been brought up in, their child has an increased risk compared to them, and trying to explain how that might be a problem and get outside more. I tend to talk to parents about healthy visual diets because they understand about healthy diets. So I see lots of children under the age of 5, which in the UK means that not many of them are myopic. But I see a lot of parents come in with these children who are already myopic themselves, and we can talk about healthy visual diets and how they can be proactive around maintaining good eye health through balancing the time they spend doing different things. And because they understand nutrition in a balanced way, I think that does help to make sense to them. Can I just, I know we're coming towards the end of the seminar, but I'd really like to make a plea for children with special educational needs and additional needs too. It's really sort of, I know the focus has to be initially maybe on typically developing children who are neurotypical, but there's so much need amongst children who have additional needs, and it's very much more difficult for them to sort of flag up their challenges, because if they fail at school, they're expected to fail maybe because of their learning disability. but actually it could be completely being compounded by a visual need that's not met. And there are so many interventions that we can do to make visual outcomes better for children with special educational needs, as well as for all our neurotypical kids too. So I'm sorry, just wanted to throw that in there.
Thank you. I think it's integrated, people-centered eye care is not just about a certain group of people. It's for everyone. Everyone needs care, and everyone needs that equal opportunity to access care as well. In the interest of time, I'm sorry, I'll not be able to get to you, Rizwana and Malka, on this question. But I would like to wrap up the panel discussion with an elevator pitch. And this is the time when I really, really want to focus on what do you think we need to do now? What is the most important action that you think we should take right now so that no child is needlessly blind or suffers due to poor vision? I'm going to give 1 minute to each one of you. And I'm going to start with Rizwana. I see you smiling.
No, I was quite, I really felt very happy when Catherine brought out that special children. So my heart is just around that. Like, of course, it's important to focus on typically developing children, but yes, and I can speak about it for hours. But if there's one thing that we need to be focusing right now, I think it's definitely improved engagement among all concerned stakeholders with more awareness, especially because there are a lot of barriers to among parents, especially parents and the people that are part of this whole food chain, in terms of seeking eye care, understanding those barriers and then be able to provide solutions to those barriers, which are again very community specific and country specific. And even in recent publications, it's so surprising to see that parents do not want kids to wear eyeglasses. So despite all the efforts that you put into providing services, I think at the back end, it's important that we work on changing the mindset and improving awareness about the impact of vision. So to me, I think the important piece is to definitely bring in improved awareness, and how you have elevate, integrate, and activate. I think it's important to empower stakeholders, incorporate evidence, and advocate for change. That's something that I would like to be putting it as my cent for the EI and the A.
Thank you. That's very that's very thoughtful. Catherine, can I come to you?
Sorry, couldn't find my unmute button for a second there. I haven't prepared anything for this 1 minute, but really just listening to everybody about this idea of being integrated. And that means integrating into government and policy and strategy as well. So it might not be an area that we're very comfortable about. And that's why the IAPB is an important stakeholder, because I think you have those people that can be advocates, that can lobby, that can look for appropriate avenues across different regions in the world. So that idea of being integrated and embedded, I think we just need to look higher than just the professionals, than the parents and the children, although those are all really important areas, and the educators of all the eye professions, the teachers and so on. But getting into those government spots, getting to speak to those influential people, making them really understand, telling them stories like Priya's story about the child that she saw, having real sort of evidence-based but case-led advocacy, so that the problem has a name and a face, and we have the solutions ready to provide. I think that's what I'd wish for.
Thanks, Catherine. Melka?
Yes, so it's mainly around what my colleagues have talked about. That is the ensuring that the government has been well advocated, because it has all the powers to give to tell everybody underground that they need to take care of children's health, so they can establish programs that will be suitable and sustainable for child eye health. And so once we do that, we need also to ensure about training of those who get in contact first with the children at all levels, but at the same time ensuring that the parents they are the ones who will decide to take the children to hospital or not. Or they may have their own beliefs and thinking what to do when their children have an eye problem. So all these together, they have to be done together. It is not one thing that can help child eye health.
Yeah, absolutely. Thank you all so much for joining this discussion today. And on that note, I would like to wrap up today's webinar. A big thank you, and I would like to mention specifically Jude, my colleague, and my colleagues at IIPB for being supportive and helping with shaping up this program. A special thanks to Cooper Vision for supporting this initiative, and each one of the panelists and speakers who were there in webinar 1 earlier today, and now the 3 of you who are with us. Thank you so much, and have a great day, everyone.